Thanks so much to the Prevent Cancer Foundation for the invitation to speak today. I'm Dr. Ophira Ginsburg. I'm based at NYU Grossman School of Medicine, and I'm going to speak about the elimination of cervical cancer. How do we get there? I have no financial relationships to disclose. In the first slide, I want to draw your attention to recent data published in 2020 from 2018 estimates of the age standardized incidence rates for cancer among women. I just want to note here that we're talking about biological sex here, but in fact, the information I'm giving today, I hope, is seen as being very inclusive of all genders, anyone who's at risk for cervical cancer. So this first slide looks pretty pink, doesn't it? And pink is associated in the slide from IARC, the World Health Organization's Cancer Research Agency, with breast cancer. And you can see that in 156 countries, breast cancer is the top cancer among women in terms of incidence. But the second most common in 27 countries is cervical cancer. Now that's something to keep note of for the rest of the talk. Cervical cancer remains the #1 cancer among women in 27 countries, despite being entirely preventable. You can see here most of the countries, but not all, are in sub-Saharan Africa. Here we see Bangladesh, and here we're in South America as well. In the next slide, I'm going to show you mortality data. Look what happens when I switch to mortality. The colors have changed. I'm going to go back again to incidence. This is the incidence. It's something called age standardized incidence. So it takes into account the actual structure of the population, because different populations, different countries have different age structures. As you know, we are much older in North America than the average person in sub-Saharan Africa, for example. This is the incidence, and again, the mortality. And you can see here in North America, this is my native country, Canada, and the US where I live, we see that this has changed because breast cancer is not the #1 cause of cancer-related death among women, but indeed, this is lung cancer, right? It's a good news, bad news story because more women, of course, were smoking over time. Many years ago, there was a huge increase in women smoking, and now we're seeing, unfortunately, the impact of that, although that is starting to shift in North America. We also know that breast cancer treatment has become better, and early detection efforts have been very effective. Enough about that. Let's talk about cervical cancer. You can see here that much more of the map of sub-Saharan Africa has changed to orange, which means in 44 countries, mostly in sub-Saharan Africa, but also in Bangladesh here, and you can see in some parts of Latin America, cervical cancer is the #1 cause of cancer-related deaths among women. And indeed, it's the epitome of disparities. Almost 9 in 10 women who die of cervical cancer are living in a low-income or middle-income country. That's more than 350,000 women every year dying. 1 woman every 2 minutes. All of these are preventable. When we look at this by region, this is again from the IARC, WHO's Cancer Research Agency, we can see in terms of sheer numbers, most of the women dying of cervical cancer are living in Asia, and Asia broadly including all of Asia, South Asia, India, Bangladesh, etc., and Southeast and East Asia, including China. So yes, the population, of course, is much larger in Asia than elsewhere, but look how much the contribution is from Africa here. That's 81,000 women. Whereas in North America, the numbers are much smaller. But please don't mistake what I'm saying today. Any death from cervical cancer is a tragedy for the woman, of course, and for her family and her friends and her community at large. And in North America and other high-income countries like Canada and the US, we do see that the preponderance of women who die of cervical cancer are marginalized. They tend to be women who are poorer, who have lower social and economic status, women of color, women who have ability issues, and other minority communities. Same goes for women who are of migrant origin, who are refugees, etc. And so in 2018, the Director General of the World Health Organization called for all countries to take action to help end the suffering caused by cervical cancer. And he noted that cervical cancer strikes women in the prime of life. Not to say that anyone over 50 is not in their prime, myself included, but indeed, this is making a special effort to note that women tend to be of reproductive age and also women who are raising families as well as participating in the workforce, Also the health workforce, by the way, which is another topic that's important to note, especially in COVID times. But this is a preventable tragedy. Cervical cancer is one of the most preventable and treatable forms of cancer. And so he called for the elimination strategy, which goes by the phrase 90-70-90. To reach elimination efforts, we have to align our efforts and accelerate our efforts. And each country is expected to, an aspirational goal, but certainly we want every country by 2030 to achieve 90% coverage of HPV vaccination of girls by 15 years of age. That's not to say that boys shouldn't be vaccinated, but girls really should be prioritized in many countries. Otherwise, the concern that WHO has expressed is that girls can be left behind. So at least 90% of coverage for girls and 70% coverage of the population at risk for screening, that's ages at least 35 to 45, with a high performance test. I'm going to describe what I mean by that in a moment. 90% of women who have an abnormal screening test should be able to achieve treatment of their precancerous lesions, sometimes called pre-cancer or pre-invasive cervical cancer. And 90% of women who have invasive cervical cancer should have effective treatment. And that includes systemic treatment, in some cases like chemotherapy. It definitely includes radiotherapy. Radiation therapy is a mainstay of treatment for invasive cervical cancer. And that's really unavailable in many settings, as I'll get to in a moment. This has been really well studied. The mortality impact of achieving the WHO's cervical cancer elimination targets. This was a comparative modeling analysis. You've heard a lot about modeling by epidemiologists now all over the world regarding COVID-19. The same applies to other health conditions, including cancer. And here, this was a pivotal seminal paper in 78 low-income and lower middle-income countries by Dr. Karen Canfell and her colleagues working with the World Health Organization on the elimination strategy, who said that, over the next century, successful implementation of this strategy would reduce cervical cancer mortality by almost 99% and save more than 62 million women's lives. Remarkable. These findings emphasize the importance of acting immediately on the three fronts: vaccination, screening, and treatment of pre-invasive and invasive cervical cancer. And in the next 10 years, we're supposed to get to that 1/3 reduction in premature mortality from non-communicable diseases as one of the health-related targets of the UN Sustainable Development Goals. So what will it take to reach these elimination targets in any country? This is from the WHO's Guide to Cervical Cancer Elimination. Actually, this predates it from the 2014 Manual for Cervical Cancer Prevention. That includes this very handy sort of chart for those of you who are not aware. This walks you through the natural history of cervical cancer. So unlike other cancers, including some which are preventable, we really understand the natural history of cervical cancer. Not 100%, but much more than we understand for breast cancer, for example. And here you can see around the age of 15 or whenever sexual debut occurs, first sexual experience, we have HPV infection, and this is so common. Most people who are sexually active will be exposed to HPV, including the cancer-causing or oncogenic subtypes of HPV during their lifetime, but the vast majority will not lead to cancer. And I should say that HPV is associated with 6 cancers, not just cervical cancer, but that's the focus today for this talk. And we see that this peaks and the precancers start much later. And so this is why we don't want to screen girls who are 15 years old, for example, because most immunocompetent people with a strong immune system will clear those infections, but some will go on to develop precancer. And if it's not detected and treated, unfortunately, cancer later on, 30s, 40s, 50s, 60s. So how do we close this gap? Well, we know about highly effective ways to screen for cervical cancer, including by Pap tests, but unfortunately, outside of the setting of high resource, high quality health infrastructure, it's really tough to scale up effective Pap-based screening and related treatment programs. It just hasn't worked out in so many countries, although in North America and Europe and Australia and many other settings, it's been very effective. And you can see dramatic decreases in the mortality from cervical cancer where such programs have been effective. So the World Health Organization and others started looking at visual inspection with acetic acid that is literally vinegar as a way to show abnormalities on the cervix during a gynecologic examination, and even to provide treatment right there and then in the same visit using freezing with cryotherapy that can include one of two gases, carbon dioxide or liquid nitrogen. But the problem is the tanks are heavy. It's hard to secure sometimes a consistent supply of the gases, and it's just been very difficult to scale. It hasn't been effective. There are lots of quality challenges, quality control challenges as well, with visual inspection with acetic acid, even in the hands of very well-trained health providers. For treatment, we now have something else called thermal ablation. We need to get the cost down for this, approved by WHO. And we also are still learning about how to best decide who should get treatment, even if it's based on HPV testing. Now, that's not HPV vaccination. That's actually looking at evidence of DNA from the human papillomavirus in the cervix, which is now the mainstay of primary screening in many settings, including here in the United States. But if you just treated everybody who was positive for HPV, especially in a setting like here in the US, where the risk of cervical cancer, the prevalence is actually quite low comparatively because we had decades of Pap tests, we would be over-treating a lot of women. And that's not a small issue. So we need to decide how best to triage those women in such settings, or whether indeed in other settings, such as sub-Saharan Africa, with high rates of co-infection with HIV, human immunodeficiency virus, that's a major risk factor for dying of cervical cancer. Those women tend to not have as good an immune system. In those settings, maybe HPV positive and treat is the way to go. But the problem is it's very expensive. It's not yet affordable in most settings, even though HPV testing is very cost effective, as I'll show in a moment. And so this is where we're at in much of the world. This is a major obstacle we have to overcome. We also need POC, which is point of care technology. So the HPV testing result can happen in real time while the woman's waiting in the waiting room, something like an hour. That would be fantastic if we could do that. There are certainly innovations on the way. There's a pipeline for innovation, but we haven't really seen it yet in a real world setting outside of a research situation, and certainly not in an affordable way. So what happens is the woman is tested. Hopefully she's notified. Maybe that can be done by cell phones, by text messaging, or otherwise. But the women who have an HPV positive test need to come back another time. And that's where we lose a lot of women. That's a really major cause of loss to follow-up. And ultimately, the woman will present later with advanced cervical cancer, even though she's had a test that showed she had a pre or likely to have a pre-cancer. And so that's another issue we need to work on through patient navigation and through, ideally, a point-of-care test. We have HPV self-sampling. This actually should be self-sampling, which means a woman can do the test herself in the privacy of her own home, for example, and at her convenience. And when we were asked, many researchers who work in different countries like I do are asked, well, maybe women won't want that. They're going to trust the healthcare provider to do it. In fact, that question's been asked in many countries now. And certainly some women will prefer that, but many, in fact, the majority, in every setting that I've seen anyway in the literature, women do prefer to do their own testing. And you can see how that could help close the gap, especially on women who are harder to reach, who may not want to have a gynecologic examination, who may be marginalized for many reasons, but they may prefer this. It hasn't been widely rolled out yet, but it absolutely should be. And again, this could be a game changer. And lastly, to mention an important emerging technology is something called visual assessment that's automated, or AVE, which was developed by the National Cancer Institute team of scientists led by Dr. Mark Schiffman and colleagues elsewhere. And they're using what's called machine learning, which is akin to artificial intelligence, to teach the computer to actually identify lesions that look like cervical pre-cancer. And this is in development, and hopefully, because of the pandemic, things have been delayed. But the idea is you add HPV-based testing, maybe through self-sampling, and then a health provider can use that algorithm in the future, once it's, of course, validated, and they might be able to have a clinical decision support right there at the bedside to tell them whether it's safe to treat that woman or she can go home and maybe get followed up another time. So HPV vaccination, cervical screening and treatment of precancers is already considered as very cost effective, which means less than $100 per year of life saved. And a cost-effective intervention, best buys by the WHO. You can look this up yourself. This was an addition to what was the non-communicable diseases prevention and control guide that existed for 2013 to 2020. When I was at the World Health Organization, many people were working on this new version of the best buys. So we have this information. This is not something that needs to be reinvented. The question is, how do we get there? How do we put this in the hands of people? And in fact, the WHO in 2016 and since then have been speaking about people-centered health services. This was actually a resolution at the World Health Assembly that was passed several years ago. That means putting people in communities, not the diseases, at the center of health systems and empowering people to take charge of their own health rather than being passive recipients of services. And evidence shows that health systems that are oriented around the needs of people and communities are not only more effective, but they cost less, and they improve health literacy and patient engagement and make the whole community more resilient and the system better prepared to respond to health crises. So you might think, gee, that would be a really important thing to be able to achieve now in the era of COVID. So we know what to do. The question is, how do we overcome that no-do gap? And this brings in the role of implementation research, which is the type of research that many of us who are lucky enough to have funding from the Prevent Cancer Foundation are involved in. I want to make a specific comment about COVID that I've alluded to. We published this. This is Dr. Karen Canfell, who I mentioned earlier, who works with the WHO on the elimination strategy for cervical cancer. She's at the University of Sydney, representing Cancer Council New South Wales in Australia. Dr. Sharon Kapambwe, who was at the Ministry of Health in Zambia, has now moved to the World Health Organization Afro Regional Office. And Dr. Partha Basu, who's the head of cancer screening at IARC. We wanted to show an effort to compare what's happening with the COVID technologies, et cetera, against what's been happening in cervical cancer. And yet cervical cancer has been so slow to gain momentum as a public health crisis, which it really is. So how can we frame this in terms of what's happening in COVID? And some people will say, just to remind you, I forget who first said it, vaccines don't save lives, vaccinations do. And so this is sort of the principle I'm getting at. So we talk about critical cancer treatment being available to less than 30% of women in low-income countries. And if access could be rapidly rolled out to most women, we could achieve premature mortality by a third, drop by a third in a decade. And if all three pillars are achieved, as we said earlier, something like 74 million cases could be prevented, 62 million women's lives could be saved over the course of the next century, right? But we need this extended research and development pipeline to generate effective and affordable options. And that's what I'm going to encourage those of you listening who are interested in cervical cancer or cancer prevention, of course, to consider where, we might put our resources to try to get from A to B and to develop and fund implementation research so we can really do this well and quickly. We need an effective global partnership. In this paper we published in Nature Cancer, we said public, private, and civil society organizations to transcend political boundaries and accelerate the scale-up of vaccination, development, and implementation of HPV tests that's as simple, quick, and affordable as a pregnancy test, and capacity building, frontline health workers for the treatment of invasive cervical cancer. And in this paper, we actually spoke of cervical cancer as akin to a pandemic, but one that's been hiding in plain sight for decades. And I'm going to end there, and I look forward to the moderated question and answer session at the end. Thank you so much for your attention.